All right, so we're going to focus now on Chapter 17, Somatic Symptom Disorders. These disorders include all of these: somatic symptom disorder, illness, anxiety, conversion, and then psychological factors that do affect our medical condition, and then factitious disorders. So we're going to talk through all 5 of these. Somatic symptom disorder can be really distressing to the patient. It's actually a maladaptive response that has usually physical symptoms. A lot of times it's pain or fatigue that becomes the focus rather than the actual emotions and feelings. So sometimes these patients tend to seek help. They go to lots of different doctors because they can't find a root for their pain or their fatigue. And so a lot of these physicians are looking for the biological causes, and they're not typically found. So you'll see these patients as being ones that jump from doctor to doctor to doctor. The suffering that they're experiencing, the pain, the fatigue, it is authentic. They are not making it up, but it's how their anxiety or emotions or feelings are affecting their physical state. Many times these patients have difficulty with functioning because of the pain they're experiencing. And remember, this is kind of a physical experience of the emotional pain. Illness anxiety disorder is very similar to hypochondriac. So a misrepresentation or misinterpretation of the physical symptoms. Maybe they have a little headache, and before you know it, they think that it is a brain tumor. You can see the DSM criteria there for illness anxiety disorder. Preoccupation with having acquired a serious illness. Somatic symptoms are not present, and if they are, they're very mild. And usually our patient is really, really anxious about their health. Any little thing may cause them to seek medical care. You probably have experienced a minimum of this through nursing school when you start reading certain disorders and you're like, oh my gosh, I kind of have that symptom. Oh my goodness, I have, fill in the blank with whatever disorder that you're, going over in class that day. But there is extreme worry, extreme anxiety over their health. And so they are seeing also a lot of physicians and trying to make sure that they're not ill. And sometimes this has times of relapsing. So they get really good and they're like, no, that's not real. I don't have cancer. And then maybe 6 months later, the anxiety increases. And usually it has a lot to do with what's also going on in their life, the stress and anxiety with that. Conversion disorder is a little bit different, and I've got a video that I'm going to put on the playlist right after this. It is neurological symptoms in the absence of a diagnosis for a neurological disorder. So a lot of times we see motor and sensory issues. It could be as extreme as paralysis or blindness, but we typically see movement and gait disorders, including numbness, maybe partial loss of vision, and maybe even seizures. The main thing that it's kind of interesting about these patients and the symptoms they're experiencing is they have labella indifference, which means they really don't care one way or another if they have it. It's just kind of a fact. They're like, oh my goodness, I'm blind. And they don't, really freak out about it. I can tell you, if I were to become all of a sudden paralyzed or blind, I'm going to have a moment where I'm freaking out. And these patients don't. And so I will attach the video that we typically watch in class right after this so that you can go ahead and watch that. So there are lots of psychological factors that affect medical conditions. And what I think is pretty interesting with this is they have a pretty large list of those on page 318. We can see the medical condition of cardiovascular disease, who it's happening in, and many times the genetic and biological correlations. A lot of times we see this in relationship with depression or high stress, high anxiety also. We can see patients experiencing MIs. Peptic ulcer is a lot of times associated with increased stress in life, increased tensions, even sometimes often after menopause. Cancer, and we can see some prolonged intensive stress, stressful life events. These are common precipitating factors. So it's really interesting to kind of look through this list and look at some of the medical conditions that can affect psychological conditions that can affect our actual physical health. So as we look through this chapter, we start to look at the assessment within our nursing process. And we're going to assess all of these different pieces within here. Many times our patients with a somatic symptom disorder don't realize the underlying cause of their issue. So we might start talking to them about the pain that they're experiencing and start talking to them about what's going on in their life, that might be stressful, and they're going to shut down that conversation really quickly. But it is important to continue to try to have those conversations with your patient, because you do want to make sure they understand the connection between the mind and the body, or the spirit and the body, so that we can kind of begin to work through what might be at the root of these issues. As we look at, probably one of the most important things to look at this is secondary gains. You have to try to identify what secondary gains the patient might be receiving from these symptoms. So usually secondary gains are benefits because of the symptoms they have. So a lot of times the patient ends up playing kind of the sick role, as coined in our book here, and they're not able to perform their normal functions within the family, at work, and those types of things. So we kind of look at whatever personal benefit they get from having the symptoms. So it may be that, they used to, wash the car and mow the lawn, but now they can't do that anymore. So somebody else is doing that for them. It's important, though, that you don't say, so what are people doing for you now? We have to ask the question in a way that's really non-judgmental. So we want to ask, what are you unable to do now that you used to be able to do? How has this affected your life? So that we can get down to the root cause without our patient becoming defensive. I do think that self-assessment of the nurse at this point is also really important, because you can start to get frustrated because the physical symptoms aren't matching with what they should. And you're thinking that this patient may just be, drug seeking or looking for some sympathy, and you feel like you need to spend your time with real patients that have real problems. It is really helpful to remember that these physical symptoms are very real for the patient. And although they may be linked to a psychological reason, the pain, the fatigue, those issues that they have, those symptoms that they have are very real. So as we continue to look through this, the primary nursing diagnosis that we're going to look at is an ineffective coping, because we want to help them to cope better. So some of the outcomes that we might want to identify, they're going to be listed in our table 17.3 on page 324. This is another one of those tables that I love, it looks at the signs and symptoms of the disorder, the nursing diagnosis that would correspond with that, and then the outcome that we would hope for from that. And really what we want to do is get rid of the ideas of secondary gains. Whatever they're gaining from that, we want to help to promote their own self-care and really help them learn some new coping mechanisms. So pharmacology, what we're looking at here are maybe some antidepressants. We don't have any medications currently FDA approved to treat somatic symptom disorder, but we do have some TCAs, some SSRIs that we do use as off-label. The other thing that I have seen used for this disorder is electroconvulsive therapy, ECT. And so that could be helpful within this situation. Not every patient is going to respond to that very well. So factitious disorder, we're getting into the disorders now that kind of make us upset. Factitious disorder is artificial, it's deliberate, it's fake. They may be, or they are inflicting self-injury and dramatically fabricating symptoms because they want to be within that sick role. And so this is a very frustrating disorder to work with others. They can have this imposed on themselves or imposed on another. And you probably have heard this called Munchausen's. And when it's imposed on another person, it's Munchausen's by proxy. And so these are all fake symptoms or fabricated symptoms, self-inflicted symptoms to get attention and to assume a sick role. There is one more within this called malingering, and that one is the same thing except they're done for secondary gains, and typically those are for financial gains, and it may be to get insurance money or getting medications that they shouldn't have, those types of things. And so I just talked all through those three. And the important thing to assess with that and to look at is that you're making sure you're keeping your patient safe. They're probably going to need to be in a room really close to the nurse's station. If we expect factitious disorder by proxy or against somebody else, we want to make sure that we don't have anybody else in the room with the patient one-on-one. Now, you as a nurse, it's fine, but if you're suspecting, a parent, a caregiver of causing these issues with the patient, we want to make sure that they're not ever alone with the patient. And if they are, we have to keep the door completely open and a really watchful eye of what's happening in that room. So which problem here does not fit in the group? We've got A, conversion disorder, B, illness anxiety disorder, C, Munchausen's by proxy, and D, somatic symptom disorder. And you may be thinking, well, we just talked about all four of these in the same chapter, so they all fit in the group. But the one that really isn't like the others is C, Munchausen's by proxy. A, B, and D are all real symptoms, where C are fabricated or self-inflicted. If you guys have any questions over this chapter, please let me know.